Good afternoon, or good morning to people on the West Coast still nursing a coffee. For those of you who I haven't had the pleasure of meeting, my name is Matt Clancy, and I'm the Director of Recruitment, Sales, and Business Development for NEJM Career Center. Welcome to the NEJM Career Center 2021 Summit webinar. While things are significantly improved over this time last year, we're committed to safety for our valued client partners and team members. So here we are going virtual again for our educational program. That said, we're really looking forward to meeting in person in the future and maybe even clanging a couple glasses together. Coming up in this 2-hour webinar, we're welcoming 2 expert physicians to discuss topics that are especially relevant today: burnout and what physicians are looking for in a job beyond the typical pay and location conversation. A quick note before I introduce our first speaker: we're going to be doing some Q&A after each presentation, so don't be shy. Feel free to put any questions you might have in the Q&A box, and we'll make sure to address them at the end of each session with the time that we have available to us. So, up first, we have Kristine Olson, MD, MSc, speaking on burnout. She is the inaugural Chief Wellness Officer at Yale New Haven Hospital, a 1,541-bed tertiary medical center and primary teaching hospital of Yale School of Medicine. Dr. Olson trained in internal medicine and pediatrics at Yale New Haven Hospital, followed by an NIH AHRQ fellowship in health services research and epidemiology at Weill Cornell Medical College, and an executive education from Yale School of Management. She assesses and addresses how professional well-being can serve as a leading indicator of organizational performance in providing reliable access to cost-effective, high-quality, patient-centered care from thriving faculty advancing medicine. Dr. Olson served as a U.S. Peace Corps volunteer in Namibia, followed by a Diploma of Tropical Medicine and Traveler's Health from Uniformed Services University. She is a Minnesotan and a graduate of the University of Minnesota Medical School. Dr. Olson's cross-cultural international health work in post-war zones has informed her understanding of the human condition, resilience, and leadership needed to thrive. She is grateful for her role models, teachers, mentors, sponsors, allies, friends, and family. And with that, I would like to hand it over to Dr. Olson. Thanks very much.
Good afternoon. I'm Kristine Olson, Chief Wellness Officer at Yale New Haven Hospital. The views presented here are my own and not necessarily those of my employer. I'd like to thank the New England Journal of Medicine Career Center for the opportunity to speak to recruiters to take an organizational look at physician burnout. In this presentation, we'll take a look at the historical context, burnout, why it's an occupational hazard with high stakes, how we move from burnout to engaged, how we create a high-performance organizational culture of wellness, live a lifestyle of work-life well-being, and look for an organizational commitment to work-life well-being. And together we can reduce burnout, recruit and retain the finest physicians for our citizens and our patients. If you'd like to read more on the concepts presented here, these 3 resources will provide the citations and additional information, especially organizational strategies to reduce physician burnout and improve professional fulfillment, written by chief wellness officers from around the country, providing evidence-based interventions that might be applied at the various institutions and give you an idea of the concepts of what physicians are looking for in a workplace. Here we take a look at the historical context of burnout. This darker line on this graph shows the rate of rise of physicians over time, not necessarily keeping up with the rate of rise of the general population. Above that, you'll find a mountain of administrative complexity. That's a rate of rise of administrators over time, demonstrating how administrative complex our healthcare system has. And some would say strangling in red tape. In 1966, Medicare was put into law and became the primary payer for our aging population. Doctors had no doubt of their profession. Health services research also came into play at this time, especially with the writings by Dr. Donna Beeson, talking about Who determines the access? What determines things that are of value and quality in healthcare? Is it the payers? Is it the physician? Is it the patient themselves? And as we move from this period of time, we move from paternalism, where the doctor knows best, to patient autonomy and ultimately the patient experience, as well as moving into the 1990s, where the HMOs were consolidated to bend the cost curve. At the same time, the quality movement was afoot, with crossing the chasm into errors human, showing that we need to reduce errors in healthcare to improve quality and safety. And also we needed to decrease variation in care across the country to ensure that all Americans got access to the same high quality, reliable care. Due to these confluence of things, physicians were working within HMO systems and within organizational systems and felt that they had lost some of their own voice and efficacy and control over providing that patient experience. Some HMOs survived, which is a clue to what makes it successful, and some did not. Then in year 2009, we have the Patient Protection and Affordable Care Act, which brought in a mandatory use of the electronic medical record, which is also a way of tracking the quality, the reliability and quality of safety, also looking out for waste, fraud, and abuse, and improving the quality of care and starting to pay by value-based payments or bundled payments. This required physicians to move into these large organizations. There was a consolidation of markets and the largest rapid vertical integration of physicians into healthcare systems. 50 years out from passing Medicare, at the 50th anniversary at the Academy Health, a panel including Dr. Berwick of the Institute for Healthcare Improvement and Dr. Clancy of ARC talked about maybe at this 50-year mark, it's also time that we look at how we partner with physicians and to make sure that their perspective, their voice, their talents are part of the picture of making sure that we deliver the kind of care that we want to deliver, and perhaps their perspectives and voices haven't been taken into account. And that has a lot to do with how we couch the physician wellness work, as well as look at how do we manage this administrative complexity. Prior to healthcare reform, physicians were already starting to give up autonomy and higher incomes of their private practices, such that they were looking for administrative simplicity, work-life balance, let doctors be doctors, and let the large organizations, or with the economy of scale, let them manage the back office management. Although as we measure, we are still working toward that paradigm, and we're looking to do that successfully. So the first time in American history, we have fewer physicians working in community-based private practices than in any other time in history. So now what we're really trying to do is to create that kind of partnership where we get the kind of healthcare that we hope. So we call physician burnout an occupational hazard, not necessarily related to a deficit to the person who has the burnout, but mostly an occupational hazard because we see that it's industry dependent. Here you can see the work by Dr. Shanafelt and colleagues that show that physician burnout is dynamic and much higher than the general population. You can also see that satisfaction with work life is dynamic, whereas improving in the general population. You can see in the graph above that across all of the specialties across the nation, that burnout is moving in unison across the specialties across the nation, giving an indication that it's something going on with the industry. We also see that it's temporally related to entering medicine in the clinical work. We see from the work of Dr. Dearby, Dr. Brezzo, that you have a higher quality of life, lower depression, lower burnout prior to entering medicine compared to your cohort, and then entering that you start to experience some of these symptoms. We also see a dose dependence with the FTE, that the more exposure to FTE, the higher the burnout, and also the possibility that decreasing the FTEs can sometimes be protective when you need to recover from burnout. We know that education is typically protective against burnout, but we see with doctors, MDs, compared to other doctorates, that they have a higher risk of burnout and not necessarily protective. We also see from the work of Dr. West and others that interventions that work on the workplace improve burnout, reduce burnout more than does individual-based interventions. And Dr. Noseworthy and other healthcare CEOs call this a public health crisis, that we need to get people working at the top of their license, reduce some of the obstacles of being successful at work, and reduce burnout. It's a national crisis. So we call burnout a leading indicator of organizational performance because we know it interferes with some of our goals. It is difficult if you're feeling burned out to have a really great patient experience where you're present with that person. You are developing that reciprocity, that trust that goes into the adherence in the recommendation, the trust in the recommendation, and the follow-up care. We also know that can interfere with quality and safety. And here we see that when physicians don't perceive quality to be present, that 83% are experiencing burnout. Here you see when physicians feel that quality is present, that there's a low proportion of burnout. And this is often why people say it's not burnout, it's moral injury. Moral injury, feeling that the workplace is somehow frustrating their objective, their need to provide that high quality care for that patient. And what we're really trying to do is create environments that allow them to have that sense of accomplishment. We also know that it can interfere with the access to care if physicians leave the workforce, aren't available for certain specialties, they are not available for clinical work. We also know that the cost of turnover is anywhere from $500,000 to $1.5 million per physician as they leave or vacate those places. Their productivity, their if you're a specialist, you might lose that whole service line, have to rebuild that and get someone recruited, and then you might have to recruit them with higher incentives and then get them working up to par. It also affects the ability to teach, research, and lead. It interferes with everything. So having a healthy workforce really helps us to achieve the goals we're trying to achieve. So we also look at the lagging indicators of burnout. So we know if burnout is present that we might see these lagging indicators. We might see errors. We might see a poor patient experience. We might notice that people can't get access to some of the services they're looking for. And it can have personal consequences as well. Broken relations, substance abuse, and suicide. We know that physicians have among the highest suicide rates of the other jobs, and 400 physicians are lost to suicide a year. That's a moral imperative that we need to reduce that. And we also know from Haven, our authority in Connecticut, to help rehabilitate impaired physicians with substance abuse or other things that interfere or compromise their work. We know from them that physicians are actually very successful in complying with and achieving success in these programs. And that there's a movement around the country to not necessarily ask about these past events when you're credentialing or you are looking at licensure, because there's a real stigma and fear of losing your livelihood and your status and your reputation and your ability to do the work you love if you fear that this will be found out. And so people go without care, and they should be role models for getting care. We also know that physicians will withdraw in response to burnout. These are also lagging indicators. We talked about this with presenteeism. They may be physically present, but they're not really checked into their work. In this case, you might find a resistant workforce in which you need to compensate higher, incentivize higher, moonlighting rates higher to get them to work. They might accidentally be reckless because they're not totally present and get errors. Risky, as we talked about. They might use workarounds to get past tasks that cause them burnout and stress by using deceit. For example, if they wanted to get an MRI or a CT or something that otherwise was prohibited by criteria, they might do something there. Some may re-engage to try to reduce burnout and be a part of that, and some may be disengaged from the organization, not part of the community, losing that cohesion, and just kind of showing up. Absenteeism, and so this is important, I think, for you as recruiters. In the work done by Dr. Sinsky prior to the pandemic, finding that 20% of the workforce plan to reduce their FTEs and not be available for clinical work. And 27% of the workforce also talked about leaving their current practice. So they may retire early, they may reroute their careers into non-medical or non-clinical work, leave medicine altogether. And a third of those people are a revolving door looking for that perfect place to work, which you will find for them. So when we think about professional fulfillment, we often think, and you might think as recruiters, that you find the people with the best credentials and the best skills, and that that's going to give you a high performance and the best outcome, the outcomes that the organization is looking for. But we know that the work environment is the process or the culture in which they work also has to support that person's success. And so this is some work that I did as a fellow for NIH ARC in health services research, and building out some of these models that originally started with Dr. Donabedian, where we look at how are the missions and values that the organization have and that the leaders espouse aligned with the work that the physician needs to do? How are the allied teams of allied health professionals working well together? How do your colleagues work well together? Do you feel that appreciated and cohesive? And how do you feel that you belong here and that you fit into this workplace? We're also looking for a sense of reciprocity. Mostly the reciprocity is being able to deliver a high quality care to the patient and feeling pride in your work. Also reciprocity amongst other colleagues in how well we take care of one another, and also how we feel that the healthcare system is just and transparent, and the return and the compensation that they might receive for the work that they do. They also need a functional workplace such that they can manage the hassle, which is the load and the pace, or the hustle, and the hassle being the efficiency of the work, such that it's efficient and with ease, that they can manage their practice and their decision making to be in service to that patient, because that physician satisfaction and patient satisfaction is really the relationship between them and the ability to get that quality result where everyone feels satisfied and fulfilled. So here we're taking a look at the mechanism that might explain some of burnout and how we can move to engage. So here is the conservation of resources theory, along with some others here, with Maslach's 3 domains of burnout being that a person may feel emotionally exhausted, depersonalization meaning cynical or apathetic toward the work, and a lack of accomplishment. And we think about the hindering demands that happen here that hinder the person from that accomplishment. And because of these hindering demands, that they withdraw their resources to protect themselves against that frustration of trying to get that work done. As we remove those hindering demands, we can get people through to satisfied, and then we ultimately want to move them to engage. And we think about Shefali's definition of them being engaged, really dedicated and committed to the work such that they're absorbed in the flow and it's invigorating. These types of challenging demands are those that are really have a lot of intrinsic motivation for the physician. They're challenges that they want to conquer and that they feel accomplished through conquering these things, that they've improved the lives of their patients, they've advanced themselves professionally, and they've been in service to the organization and the mission. We also have to watch out for workaholism, where you can also overinvest and run into some of the same issues. So when we look about creating that type of environment and what we look at in our annual wellness reports, what we look at, what we want to intervene on and how we do that. So we're looking at the culture and climate, those relationships that people have with one another. We look at the practice efficiency and the ability to support that physician's work. And we look at personal resiliency and that person's ability to maintain work-life balance so that they can go home, they can rest, recharge, and be ready for a new day. They can spend time with their hobbies, their loved ones. Job crafting can help them to craft that meaningful work for themselves to some extent, to be able to tailor this for themselves. And the peer support that others can offer, where only other physicians can really understand what it is they're going through and what it means to be resilient and thrive. So Zizali looked at physician culture using the competing values framework and found that physicians really prefer a participatory team, group, collaborative style of working, and that they also like a rational, productive, competitive style of working. They're a little risk adverse when it comes to being entrepreneurs and innovative. That's understandable. It's also understandable with people with high stakes, complex decision making, that they would not prefer a hierarchical, bureaucratic, controlling structure. And so as we try to develop these partnerships to make our organizations dynamic and really high performing, we think about how we can do this. So the first thing that we can do to help to create this is leadership. So we know that physicians are likely to leave based on the culture and climate set by leadership, that they're likely to leave if they feel people don't care about them, if the leadership doesn't care about them. And so what we find is a movement in the wellness community to move away from command and control like structures, which can make things happen fast and put structures in fast. And there's occasions where that's necessary. But then when we're creating these partnerships and we're really engaging physicians' voices and talent, looking for a transformational style leadership might be one who's charismatic in leading and inspiring people in the good of the organization, or a servant style leadership in which the leader leads with humility in leading autonomous people who are intrinsically motivated to be in service to the organization and the task at hand and that which they're trying to accomplish. We think about collaborative, distributive styles of communication, two-way communication. We think about contingency management, in which these high-stakes, complex decision makers, that decisions require that two-way communication, their input, their buy-in, contingent on their buy-in, so that they can rapidly adopt it, knowing that it's not going to adversely affect the work that they're doing. We like to see fidelity to mission and the values aligned, and something bigger than self that people can feel proud in. And in the end, with both leadership, teamwork, and a gratitude culture, people will feel seen, heard, valued, developed, such that they belong and believe, they're engaged and empowered, they feel intrinsically motivated, committed, absorbed, and invigorated. So you can ask your clients too about in what ways they would like to accomplish some of these or how they see that for themselves. We also need people who know how to be team players and how to lead teams, and some of the things to look for. And some of the goals are to work in unsiloed, team-based share the care style, such that everyone's working to the top of their license. Some of that is going to come from practice efficiencies, because we know that everybody's spending a lot of time documenting and things like that. So that'll come later. But such that people have clear goals, clear roles, a transparent scorecard, that everybody maintains some self and situational awareness. And by that, I mean, you would know that if you're extroverted, how you might affect an introvert. If you have these values and someone else has different values, if you have a certain personality, about how you operate and how you affect others, and how to also appreciate that others have different styles, such that you can be empathetic and offer mutual support and develop a sense of collegiality and community. That sense of psychological safety to disagree and to quickly resolve conflicts and learn from mistakes. Notice when people are holding back or inauthentic, fake niceness, or venting, triangulating, or a sense of favoritism in politics. And what does that tell you, and what does that mean, and where does that create the opportunities for improvement? These things are also consistent with high reliability organizations. These can be challenges for large organizations who tend to standardize things and have become more rigid because of their large size. And you can lose efficiency because of that. And you can lose that local feeling, and you can get into a situation where you can say, not my job. But we're trying to create that local feeling and that sense of collegiality and mutual support. This can also be challenging under stress. If the workload is very high, or in the middle of pandemic, people can feel irritable, and what we can do to address that. When you're working with clients, whether they're leading or whether they're coming into the organization, everyone has something that they need to get, and they also have something that they can give to their community. Some of the things that can get you at how people are motivated is looking at who do they see as a role model? How do they want to show up for work? In what ways might you find a good match for them, where they might find just what they're looking for, based on knowing what their role models are, to give you a hint of what kind of work life that they're looking to achieve? In what ways do they see themselves as role models and that responsibility? Mentorship, what kind of mentorship would they like to have? What's the kind of mentorship that they've received and what they liked about it, and how they'd like to be mentors to others? In what ways does this organization have executive sponsorship, in that someone will help to develop them and remove obstacles and give them upward mobility? Does everyone have equal access to that? Are there allies to point out implicit bias and look out for you? Are you able to say, oh, ouch, oh, that was an implicit bias. Oh, oops, I didn't mean that, I apologize. Are there ways to raise awareness of implicit bias in this workplace? Peer support. Are there people that understand the work that you do? So if you have an adverse outcome, is there someone you can talk to who you know is going to understand you, and you don't feel so nervous about speaking to someone because you need to process this experience you've gone through? Or peer supports who can help you to achieve what you wish to achieve in your professional life? What kind of support is there for this person to grow and thrive in the organization? Are there coaches? What do you do to improve collegiality? Is there a way of social cohesion? Do people consider each other friends? Do they get together for commensality groups, or share a meal, or share the experience of work, such as what Mayo does with the Compass groups or Valiant groups? How do we create a sense of community? Are there social events? Are there Schwartz rounds of ways of sharing the experience of work? And do they accommodate that you have family and friends? Belonging. People want to know that there's respect for diversity, equity, inclusion, because we know in medicine that we have the same amount of explicit and implicit bias as the general population, unfortunately. And given the high demand, low resource states that we sometimes find ourselves in requires rapid decision making, that we sometimes rely on these cognitive shortcuts prone to implicit bias. And that can inadvertently hurt someone and bypass qualified candidates for opportunities. So people will want to know, are there people like me at the top? Will I have some upward mobility? Will I be accepted as I am? Is there, or will I have to conceal myself? Will I feel isolated, lonely, and stressed because I feel like I can't be myself or I'm not valued as myself? What mechanisms does an organization put in place to raise that awareness and have those allies, bystanders, upstanders? And in what ways do we evaluate people to make sure that those evaluations, those opportunities are equal and fair and everybody has a chance to succeed? Professionalism and belonging. We have a system similar to what Jerry Hickson has at Vanderbilt, which he describes, where you will have an if a professional event has come up and people have questioned some of your behavior, that you would sit down with the peer and have a cup of coffee with them, a leader peer who has the responsibility of looking out for your professionalism, that you have a chance to respond to that, to improve on that. And then there's a very transparent process of what the steps are if that weren't to be corrected. So it's very transparent and it's very respectful. And then the skills to help us to be professional. For example, do you have ways for mindfulness-based stress reduction, for example, a way to regulate your emotion and to catch that moment of pause to choose how you want to show up? Cognitive behavioral therapy styles. Our thoughts drive our feelings, drive the way we behave. For example, if you are trying to transfer a patient to the intensive care unit and they block you, you might feel stressed because you're going to have to manage that patient and you feel upset with that person and you feel like they shouldn't be blocking you and you might be rude to them or say something bad about them. But when we change the thought that they're trying to block you or just not being cooperative, to say, wow, they must be very busy there, they must have a really heavy workload, then you start to feel more empathetic and then you behave in a different way. Emotional intelligence also can be taught in a way that we can recognize with nuance and specificity what's the emotion that we are feeling or that we notice in someone else. Can we name it? And then can we respond to that and express and close that loop with ourselves or with that other person, our colleague, to be also supportive of them and give that opportunity to share your experience. In what ways do we have situational and self-awareness, as we spoke of, with your own values and styles and personality, and how that affects others, and how that affects our ability to have conflict resolution that's quick and easy and have that sense of connection and ability to be masterful in our work? Practice efficiency is really important in creating the time and space to do any of these things. And so you may have heard of the analogy of what's in your backpack, what rocks or heavy load in your backpack belong to you versus others. Here you can write your workload and you can write who helps you to do that. First, find out what belongs to other people and make sure that they're accountable for their share. What belongs to you and only you can do, and what on there, is there someone to help you carry the load or a resource that you can reach out to? And then how do you do that? As we engage physicians and their talent and their expertise in their fields to really improve the quality and the safety and the patient experience and their own experience in their own fields, we are looking to engage the MDs in this iterative improvement process that's mission-driven and human-centered design. And how do we get them to also express all of the expertise that they have in their area in a way that can be carried out or expressed to a business person, of showing what's the magnitude, urgency of the situation and the clarity of which you present this problem and the return on investment we can expect. What's the situation, background assessment, recommendations, who needs to be informed upstream and downstream, who will be affected. There are many different ways of going through an iterative process of improvement so that the physicians then can be partners in improving quality, safety, and the patient experience at a very affordable, high value proposition. The administrative load in the EHR. So people are looking for, in what ways does this organization recognize this and how are they trying to tackle it? Our own CMIOs have always been partners in this work, care a lot about the well-being of the medical workforce, and they measure the documentation time, how work after work, time spent documenting during encounters and in baskets and orders and pre-authorizations. And they work to combat the number of clicks, the number of time you're spent documenting so that you can spend more time in patient-facing, really meaningful work. And so people are going to want to look for this in their employment to say, how do you make it easy for me to accomplish that really high quality experience for my patient? Some of the principles expressed by the AMA in their executive reports or the American College of Physicians is in healthcare strangling and red tape, is that we be careful, we refrain from how much we put in there, that we think about the impact that implementing policies are going to have, that we review things periodically, reduce them, eliminate them, simplify, automate, streamline, share, and assist. Millennials and others, we've seen from through the pandemic that parents and their work-life integration, their ability to homeschool and childcare and whatnot, that has affected their ability to be engaged in full-time work, and they are not able to be on the same grants and the papers and the patients and the full-time FTE. And the millennials are certainly looking for ways to have a flexible work life. They're looking for what opportunities are there to perhaps work part-time when they need to, or to job share, to share a panel of patients, to work longer extended hours so they can have more time off, to work shorter hours so that they can pick up school-age kids. Ways to really be creative and engage people in a way that gets them working to their full capacity, keeps them retained at their full capacity, and the ability to maintain that work-life well-being. And if we're doing a good job at creating professional fulfillment and that they are committed, invigorated by their work, I think we would find that they're going to want to work to their greatest capacity, and we're going to see them increasing their FTEs. They're looking for ways the organization shows support for that integration. Is there administrative assistance for things? Is there concierge services, lactation rooms, on-site childcare, elderly wellness checks? Are there on-site exercise facilities? Are there healthy choices for meals, sleep pods for those who are overnight and have to stay later for whatever reason on call, financial advisors, stress management? What's available to them to really that they can reach out and they can have some control over crafting this for themselves? And in what ways can you have a conversation with these candidates to know what would you like to improve so that you can rest and recharge? What are your hobbies? What kind of things do you like to do to socialize or spend time with others? Are there philanthropic or altruistic things that you like to do? What type of exercises do you like to do? These can also help to open up new opportunities of locations where they might have not have thought of before, but it might appeal to them because they see that this other thing that they do to rest and recharge is there. Because we want people to have the opportunity to rest and recharge so that they can come back ready and raring to go when they are doing the other work that they love in caring for patients. And how do we think about thriving at work? This is Dr. Seligman's PERMA model. I added a little more description to that. I hope he doesn't mind. And ways to find out that, are you able to maintain optimism and hope in healthcare? Why or why not? Do you feel engaged and in the flow in your work? Why or why not? What's the obstacles? What can we do to get you in the type of job where you're going to thrive? What does it mean to be connected and supported and values in those relationships? What do you feel is your meaning and purpose in this, your calling bigger than yourself? Maybe there's an opportunity to find a match here with their purpose. What does it mean to be accomplished and have a sense of mastery and efficacy in your work? How also can you craft that such that you can have a sense of health and vitality and vigor and be rejuvenated? So these can also help you to get that person into the right job and to open up their ideas of different locations or different possibilities, or how to appeal to them to get physicians where we need them to take care of our citizens and our patients. And let's not forget that we're in the middle of a pandemic, and we started with high rates of burnout before we started this pandemic. People went through very high adrenaline state called the healthcare heroes. And now this pandemic is going on, and people are fatigued and irritable and all the symptoms of stress. And and they're making choices. They're reevaluating their priorities. They're reevaluating work. They're thinking about what they want it to be in the future. And you have a real opportunity here to really help shape, craft people's lives and also the work environment to help make it match what people are looking for. And hopefully what we talked about helps you to also ask the questions and really get at what they're looking for, so you can be open to new possibilities and appeal to them in ways that they're motivated. And do they have a practice that, even with all the stress and the high volumes and the burnout, that do they have a practice in which they can take a pause and between their reaction and their response, fill it with something else? And I talk about give your day some gas, fuel your day with gas. So gratitude, it's greater to give than to receive. Awe, a sense of wonder and wow. And savor the moment, soak it in, take a moment whenever you can, whether you're washing your hands and taking a mindfulness moment or whatever thing you do. So we measure all of these things in our annual wellness survey. We look at for high yield opportunities or workplaces of where we can help to intervene and craft on these. We look at the levels of the individual, the work units, department sections. We partner with our stakeholders. We're not doing redundant programs. We're partnering with them to show them where those high yield opportunities are. We're working with our policymakers and our regulation and compliance and how we do that, keeping in mind the professional fulfillment of our medical workforce, and also how we can be partners in the legislative process. So work-life well-being as a priority, will have someone to lead that. They will look for best practices, teaming up with partners nationally, team up with their local wellness directors and leads, be able to communicate that, measure that, find the high-yield opportunities, and really have a robust initiative. So in the end, when we talk about how to recruit and retain, we want people to be engaged and empowered. We want them to belong and believe in the organization and what it is we're doing, such that it's mission-driven and value-aligned, appeals to their calling and something bigger than self, that we are all in this together doing one really important mission, and that people feel seen, heard, valued, and developed. That the individual does, but they also see an opportunity to do that for others. We want them to be engaged and empowered in the improvement and innovation such that they belong and believe in the organization that they're doing, the work that they're doing to make it really the best. We want people to feel engaged and empowered to live a meaningful life, to rest and recharge and to be happy and to come back ready to go. We want people to have a sense of calm or a positive outlook, control, or feel that they don't not have control, that they have some latitude of control, and they feel connected with others. And Adam Grant talked about meaning, mastery, and mattering to others. And so we would like to create opportunities for all of our physicians in the United States to feel this, experience this, and you can help them find that perfect match, that perfect fit, and help to shape the future of healthcare in the United States to reduce burnout and recruit and retain. So thank you so much. Together we can end burnout and thrive. We can get medical professionals fulfilled and absorbed in meaningful work done masterfully with pride and vitality. I really appreciate your time today, and feel free to reach out to me if you have any questions. And thank you for all the work that you do. Really important. Thank you.
Awesome. Thanks, Dr. Olson. I think given all we've gone through with COVID over the last, it's hard to believe it's 15, 16 months at this point. Given all we've gone through, I think the concept of physician well-being is really important. I think in terms of retaining staff, keeping staff productive and happy. And also, one of the concepts that's going to be familiar to this group of attendees is the recruitment aspect of it, right? It's a portion of retention, but it's also a portion of what if my organization is doing these things? We're doing them well. How do we communicate that to to future candidates? And if we're not, there should be some takeaways here that can potentially be taken back to be focused on and worked on and make that experience for current physicians really fruitful and make the opportunities more appealing to future candidates. So we do have a couple questions to run by you, and we do have some time to go through them. So I think one of the overarching questions is going to be sort of application. I think a lot of these make a ton of sense, and maybe as somebody who is really knee deep in this stuff on a day-to-day basis, the implementation and tactics associated with it could be interesting. But let me jump in on the questions that we do have so far. The first one is, what methods, a sense of belonging at an organization, what's really the best way to, physically employ that sense of belonging with your current physicians?
Is to make sure that they feel seen, heard, valued, and developed. And in the ways that we do that at the leadership level is to have that transformational servant leadership style, which is about making sure that their input is heard, that they're transparent with information, that they seek their input in implementing things to get their buy-in, to do value aligning walk rounds, for example, to make sure that they're heard and that they reflect that back. To make sure that when you do a survey, that you get those results back to them, that you activate them, that you communicate them, to make sure that there are opportunities for them to not feel hindered by an obstacle at work, but that they actually have an outlet where they can express how difficult an obstacle is and have an outlet that the organization either creates for them. An example of that would be our Building Against Burnout program that our CMIOs have, our Chief Medical Information Officers have, where they've created this structure where you can learn how to master the EHR so that if you wanted to, you could be in charge of that yourself. Making sure that there is an opportunity to, as a leader, bring your team together to talk about the emotional side of work and to also do Workflow mapping is another thing that Kristine talks about a lot, where you can have monthly workflow mapping where you look to address some of those hindering obstacles, but that you have numerous ways for people to have their voices heard and responded to, and that they have power to engage in the workplace to make their specialty, their department, their section the best that it can be, and that they can have a sense of pride in that accomplishment.
That, I think as I listen to you, some of the more sort of big rock takeaways I'm hearing from that is, maybe something that's just kind of relevant in life overall. What I'm hearing from you is communication, right? And it's not just two-way communication between, two parties involved, but it's listening as well. Understanding. And, from a leadership perspective, understanding the physician's perspective, and from the, physician's perspective, understanding where leadership is coming from. I'm hearing you say sort of top down, this has to be a priority, and it has to be something that, passionate about might be a strong word, but something that you believe in, organizationally, and you almost can't fake it, right? It'll be felt. Again, once that sort of permeates through your organization and that communication takes place, I can see how that would be, a really effective way to making it felt by your staff.
Another important part of belonging is to how you feel as an individual if you belong at work. If you have to conceal your identity, or you're accepted, or your differing views are heard and still respected. Also, that has to do with what the organization does to create egalitarian process of advancement and a chance to grow as a professional over time. And also the culture change that we do in decreasing implicit bias, to make it okay to say, ouch, oops, if someone notices an implicit bias, that it can be called out, and we as an organization do it as a routine, and it's okay, as we all raise awareness of bias.
Yeah, we're not, I think one of the big concepts that maybe just obvious but was overlooked is it, not turning the other way, right? It's actually addressing the issue that you're facing. I can see how making this, making your physicians feel comfortable through a bunch of different channels is really important in order to continue to get that satisfaction out of them. So a more candidate-focused question. Let's say you're, as an organization, you're doing a lot of the things that you described to be successful with physician wellness. How would you go about communicating that to candidates, to physicians who aren't at your company, but you really like to attract to your company?
I would say it starts with them knowing that there is a wellness initiative and that it's a priority of the organization. And then they might want to know, well, how much of a priority is it? And then it might be, well, we have a chief wellness officer. We make sure to get your input every year and to put that input to work to make sure that it gets the organizational stakeholders it needs to get to, so that your perspective is reflected, and then to communicate those results throughout the organization, and to see if you have the support of a wellness program that can really engage and empower. We have a clinician wellness council, for example, and that is an opportunity for all of our wellness leaders in the departments and sections, where they can have iterative improvement and talk about what their priorities are in their departments and sections, so that their voices are heard and they have a champion, and that it's very relevant to them and their department. It's not a one size fits all. So the organization does its work with its human-centered design or clinical redesign and making an important part of everything that we do, but also that we don't have one size fits all, that the work that you are doing has a voice and you need it to work for you where you are locally.
Mm, mm.
So I think some of those
That's,
structures, but communication is, you can't have enough of it.
yeah, I mean, I think that's sort of been the big takeaway that I've taken from this, which is, you know, at all levels of the company, there needs to be great communication on this subject. And, you know, one of the things you said that stood out to me was that physicians don't want to feel like they're a cog in the, you know, the machine of an organization. They want to feel like they're a part of it. Right. And that's where that communication and feeling heard and feeling a part of something is, you know, really important. So, you know, again, all tying back into that communication conversation and point. So here's another one. On an individual, this is actually an interesting one. On an individual level, what can we do to help initiate change in our company's culture?
It would be, I wish this were a two-way conversation, because I think it would be interesting to hear from recruiters what people are looking for now that a lot of people are moving because of burnout, and what they are looking for themselves to be happy in an organization. I imagine they're looking at supportive leadership, happy colleagues, a way of managing the workload efficiently, being able to go home at night and rest and recharge and not disappoint your loved ones, and to be able to turn off for a period of time before going back to work. So recruiters can help organizations know the component parts of a wellness program to suggest that they have them. And also, if it's not being communicated, they can ask them for that information, for that data, so that they can help communicate it. Especially through the pandemic, communication channels or resources, you know, have gone a lot of different ways to be able to accommodate the pandemic and to do that fast. So it's been all hands on deck to be able to do all the work that needs to be done. And so if recruiters can be part of that communication process, that would be tremendous, and to help the organization pull out those pieces so they can be highlighted when they are recruiting people to the organization.
Very cool. Very cool. Okay, I think we may be out of questions at this point. But a really relevant topic, and some really great information that you were able to share with us, Dr. Olson. Hopefully, as time goes on, this is adopted universally, and it's an effective resource for companies. So thanks again for taking the time to share this with both us and our attendees.
I appreciate your interest. Thank you so much.
All right, so good stuff from Dr. Olson right there. Hope you guys found that all to be valuable, and are able to have some actionable takeaways from that. Moving on to our second speaker. We are pleased to welcome Dr. Stephen Beeson. He is a nationally recognized author, physician, and speaker who has provided approaches for developing clinicians and leadership for hundreds of medical groups and hospitals across the country to transform care for patients and those providing care. A board-certified family medicine physician, Dr. Beeson practiced with the Sharp Reese Steely Medical Group in San Diego County for 18 years. During his tenure with the medical group, Dr. Beeson was selected by Sharp Healthcare Leadership to serve as the physician director for the Sharp Experience, an organizational commitment to service and operational excellence. During this time, the medical group improved their patient satisfaction from the bottom to the top decile, won 3 AMGA Acclaim Honoree Awards for clinical performance, and with the Sharp Healthcare, was the recipient of the Malcolm Baldrige Award. Dr. Beeson's first book, Practicing Excellence, A Physician's Manual to Exceptional Healthcare, became a national bestseller that articulates a prescriptive how-to approach to improve physician performance to drive organizational success. In 2009, he released his second book, Engaging Physicians, a Manual to Physician Partnership. This critically acclaimed book takes system leaders on a staged journey to physician enrollment and organizational change efforts. Most recently, Dr. Beeson founded the Clinician Experience Project at practicingexcellence.com, an app-based learning community focused on restoring the clinician experience through reconnecting to patients in the exam room, collaborating as teams to build community, and leading in a way to bring the very best from our care teams. And with that, I'm going to hand you over to Dr. Beeson.
Great. Thank you, Matthew. Can you guys hear me okay? All good? Excellent. Excellent. So anyway, it's always funny to hear yourself introduced. I feel like I'm at my own memorial service. But anyway, to give you a little sense of who I am, as Matt had mentioned, I consider myself to be a frontline physician. I've went to undergraduate medical school and residency at University of California, San Diego. I was actually born in the same hospital I worked in clinically. And kids go to the same high school I went to, so certainly homegrown here in San Diego. Finished residency in 1994, and as part of a large integrated healthcare delivery system called Sharp Healthcare, as part of the Sharp Reeve-Steely Medical Group, about a 500 physician group. And my intent was to see patients all day, every day for 35 years and call it a day. You know, life doesn't always happen according to what you think will happen. And my life began to change around 2001. I was tapped on the shoulder by our medical director, chairman of our board, Don Balfour, to coach, train, develop, and engage physicians as part of an organizational improvement effort that we call the Sharp Experience, to make care better for patients, better for our staff members, better for our clinicians. And at the time, we struggled a bit on the physician engagement front. We had physician attrition of 18%. We had litigation happening between the medical group and the hospital regarding revenue split. We had a couple of payrolls where we couldn't make payroll. Outside of that, things are going well. So we endeavored to become better, given that we had Kaiser Permanente and Scripps Health and University of California, San Diego, literally the same zip code, competing for the same patients, competing for the same clinical talent. So I became a student of what prompts clinicians to contribute to the group mission, and what prompts clinicians to say, you know, I'm a lifer here. And I think confluent with those ideas is what Kristine had shared so brilliantly, is how do we set organizational conditions that serve as a mechanism not only to keep and retain clinical talent, to access discretionary effort, because clinicians will do for the organization what the organization has done for them. But more importantly, to use that cultural profile of this is what it means to be us as a recruitment mechanism. And through the endeavor and the fellowship, if you will, of coaching, training, and developing clinicians, we were able to, as Matt had referenced, transform the patient experience, transform our financials. We were one of the top medical groups in the state in chronic disease management and quality, AMGA, Malcolm Baldrige Award winners, and we're able to drop attrition from 18% down to below 4%. And our recruitment went from 30 open primary care spots to a line of people looking to work at our organization. And though my intention was not to learn what are the things that differentiate one group from another that we can leverage in the massive shortage of clinicians, but it became very evident that there are certain organizational profiles and there's certain messaging that we provide to the physician field, people like me, in terms of what really prompts us to make a choice. And what are the features that are present in organizations that differentiate. And again, every clinician is looking for different things. Some just want to go to the place where they're going to make the most money. And I would contend, and there's pretty good evidence that I can cite many examples where that's been the worst professional decision that they've ever made. but what are the transcendent properties that we can manifest within the organizational culture and communicate to a prospect where they say that place is special, that place is different, and I want to dive deeper in this place. The first thing that I would recognize is that in this era of physician recruitment, we get concerned about filling the seat and getting the recruit, given again the massive shortage and progressive shortage of physicians. Part of our strategy of improving our recruitment was actually to make it more difficult to get into our organization. Again, we had massive shortage, tons of open spots. But what we found when we first began coaching, training, and developing clinicians, my first body of work was to coach, train, and develop clinicians who were in the first percentile for the patient experience. First percentile. Okay. We were in the 6th percentile for the clinician component, but those below the first percentile. So as I was meeting with these clinicians, it wasn't so much what skills can I give them to help improve patients' perception of care, but the real question was, why are these clinicians in our group in the first place? And I asked our board, I said, what is our screening mechanism to filter clinicians to make sure we're getting the sort of people that will position us for success? And then we realized that we had no selection criteria. Our selection criteria is, are you board certified? And can you take call on Tuesday? That was sort of it. So the first thing that we did was we built a behavioral-based interview process based upon the principle of people will do in the past, or will do in the future what they've done in the past. And we identified, what does it mean to be a clinician here? And so we went highly patient-centered, highly collaborative team players, clinically strong, and good local leadership skills. So we identified questions that we could ask during the screening process to begin to filter the clinicians that were coming into our organization. And over the course of time, we found, our board said, what are you doing putting up screening questions when we can't even fill our 20, 30 empty primary care spots? Or clinicians want to join a place that's selective, that is hard to get into, that's a champion. We don't take anybody. Do you have what it takes? Because we are dedicated to becoming the best. And the process of vigor in the selection process was actually a recruitment draw and differentiator, and powerful to us because we were getting high EQ clinicians. So that was some of the first things that we began to do in our journey from 18% attrition to 4% attrition. So did the slides advance? Matt, we good? Okay. Kristine had me a little PTSD here. So anyway, how clinicians decide, and again, I can give you a pulse on the market and a generational pulse, because young physicians are looking for very different things than clinicians that trained prior to the work hour limitations. The intangibles of selection. You know, what are the things that prompt them to go home and speak to their significant other and say, man, I think I found it. Man, I don't know what it is, but there's something about that place. So, and what are the things that really truly differentiate one from another? And a funny metaphor is my son, who's now graduated from college, was a Division I lacrosse player and went to a variety of schools, and they recruit you, they put on their best language during the recruitment process. But there was one school that stood out, and the coach met with us, and he sat knee to knee with my son Nick, and he asked my son, what kind of team do you want to be a part of? What's your hope and dream in life? And that's a lot different than looking at the weight room. And there were bigger schools, more prestigious schools, but he selected this school based upon those simple cues that differentiated one school from another. People make it based upon emotion. And is this place the kind of place I want to hang? And the kind of people I want to hang with, and do they stand for the things that I believe in? And we have to formulate our messaging and our framing so we convey the actual levers of choice for clinicians. And ultimately, they're going to say, am I going to get what I seek here? I want to have the life that I have now sacrificed so much for. And as we know, and as Kristine shared, burnout is the pandemic before the pandemic. And you have to realize that becoming a clinician is the ultimate in delayed gratification. And I hate that term. It's like, don't enjoy your life right now. Make it terrible now for the prospect of joy, contentment, and fulfillment in the future at some point. Well, I can tell you that when you finish residency, then the work really begins. And I always tell people considering becoming a clinician, if you enjoy becoming a clinician, you will enjoy being a clinician. So we have to think about the sort of things that clinicians seek, and to be able to speak that language. We got into medicine to make a difference in the lives of patients. That was the central driver that many of us was the prompt that allowed us to engage in the prompt delayed gratification. We want to be able to develop a body of abilities to make the life of the patient better through diagnosis and management and treatment of disease. What an endeavor. And so we have to be able to know what's important to them and to be able to speak that language as we frame what it means to be your organization and what you really stand for. So again, because we're seeing this heartbreaking pandemic and this heartbreaking condition of burnout, and I think speaking to clinicians that the quality of your life matters here. The people that make up the most important, the people that are in this organization are our most precious resource. And we make decisions, allocate capital, and conduct ourselves in our words and actions consistent with that. Everybody says that. Everybody says, oh, the people here are not important. But the ultimate test is, are you deploying accountabilities at the executive level? Are you measuring, tracking, and deploying action on the well-being of your care teams? Are you holding people accountable for turnover? Are you doing the things that really matter? And verify that what you're doing is consistent with your claim that the people in your organization are your most important element. I think that in and of itself is a marketplace differentiator. And I'm going to give you three things that reflect what I found to be the most powerful drivers of medical group health system differentiation that resonates with why we are here. Because I think it's a tragedy to engage in a clinical walk, a clinical life, and 2, 3, 5, 10, 15 years into it saying, I don't even like my life. I don't know if I can carry on for another 6 months, let alone another 20 years. And to acknowledge that we built a culture that is designed around people staying here for life, where they look over their shoulder after a day, week, month, year career and say, this is everything I hoped it would be. That is our focus. And they're going to go, wow, that's pretty cool. That's like the coach saying, what do you want most out of life? It's a signal that you matter, you count, and we're legit in terms of our ability to support and respond and develop you to be your very, very best. So what do we do? So before we dive in to all of this, I'm not going to cover the feature list that you guys already know so well. Money, location, case mix, generation. You guys know that stuff. I know that those are important. They're important to be competitive. They're important to be specific. Saying we have a competitive compensation package is, I think, a mistake. It's how much money will I make and what upside potential is there in people who are 5 and 10 years in, what are they making? Because in the absence of other intangible differentiators, which I think can be the hook, it's important to be very specific in regards to what we're signaling to clinicians. But we're not going to be covering that because I think that you're already masters of that. But I would be careful not to over rely on organizational feature lists, but rather cultural differentiators. And I think the bigger question, and part of Kristine's conversation, is how do we build the organizational culture, leadership structure, and leader development where these things are actually manifesting, they're palpable. And that's the larger question. I can't answer that for you right now, but I can tell you that deploying capital, effort, priority, and accountabilities for advancing the quality of life of your care team members is the best effort you can expend in all of healthcare. I mean, categorically, hands down. So, this is going to be, how do we recruit clinicians and differentiate in a competitive marketplace to recruit clinicians? But the more important, bigger question is, how do we build a culture that allows the people that are in it to say, this place is awesome? I will access my discretionary effort. I look forward to going to work on a Sunday night, actually. And I would recommend this place to my colleagues in fellowship right now, no doubt, with total confidence. Move across the country because this place is awesome. That's what we want to be able to create. And we want to be able to leverage and communicate that to the field as cultural differentiators and feature lists of competitive package. So there are three important drivers to effective recruitment. And again, there are more than three, but we're only here for a little period of time. So I'm going to talk about these in some detail and encourage you to think of your questions and your challenges. And everybody's going to say, yeah, you're in San Diego, so shut up and stop giving me things that I can use in South Dakota. Not that there's anything wrong with South Dakota, but sometimes we're in places that are not coastal communities. So queue up your questions because I know that I'm sure that's rattling around in your head now. So three important drivers of effective recruitment that we need to be able to leverage in our framing and our communication with prospects and recruits as differentiators. About these three things. We must have not only claims to them in our messaging, they must be palpable and witnessable as a cultural feature that is unmistakable in the organization. And so we're going to talk about what we say this is important for recruitment, what things are happening that are criteria for this being more than just the talking to recruit. So there has to be verification as legitimate, meaning, this feature is critical for the well-being and vibrancy of our clinicians. Here's the proof that it's manifesting. I'm going to give you some of that proof a little bit. And then the ability to frame this with great degree of pride in who your organization is, and having a very distinct organizational signature in regards to what it means to be us. We are known for, you may not be Kaiser Permanente that offers 50% of your peak salary after 20 years of service. So your feature is not, unless you've got a gigantic foundation or something, you're not going to be able to compete on the retirement plan of Kaiser Permanente. So figure out your greatest strengths and leverage that as your recruitment mechanism. And even if we have to rededicate ourselves to the well-being of clinicians, it's going to serve as an improvement lever for recruitment, but more importantly, it's going to advance the well-being of your clinicians. And as Kristine had said, we cannot subsidize the clinicians who are burned out, because every element, as Kristine had mentioned, is compromised. Their patient connectivity and the average loss per employed physician of patients migrating out of network, meaning they're just going, that's not that great there, I'm going to go see my old OBGYN. That's $750,000 per physician per year of out of network migration. About 50% of that is voluntary. So getting clinicians who are burned out and saying it doesn't matter that much because they keep showing up for work, the numbers that you're losing in terms of patients just bailing, let alone the clinician that leaves and the $1 million loss, the money loss is staggering, and the business case for wellness is not just for recruitment, but it's as I said 3 times now, the investment in organizational conditions that advance the quality of life of clinicians so they stay, advocate, access discretionary effort, and look forward to coming to work is the best money and effort leadership can spend. In my mind, every CEO should have one accountability matrix, and that is the engagement of their team. Just that's the only one in my mind, because that is the condition that allows all the other things in population health, clinical variation reduction, patient engagement, patient centricity, harm reduction. All those things require the clinician to be, let's go, let's roll, I'm pumped. I will leverage my influence in the microsystem around me to allow us to go and get this done. As opposed to clinicians crying in the back seat about the misery of their lives and how much they hate everybody in the organization. You inoculate your organization with that, and good luck getting anything done. So again, taking care of the people, not just for recruitment purposes, but for the vitality of your organization. So item 1, and you're going to go, oh, this is a nice guidance, Captain Obvious. But this is interesting. This is a study we had done back in 2018. About 500 clinicians were surveyed. And what we found was clinicians who felt they were a part of an organization that is authentically and legitimately connected to what's best and right for patients had 4 times lower burnout than clinicians who felt like they were an RVU center. And again, the differentiator is not patients come first here, because everybody says that. But the question is, when is it legit? When is it authentic? And when is it palpable and witnessable and differentiating? So a couple of things to think about in regards to this. Verifiable patient connectivity commitment. Number 1, we have robust coaching and development of clinicians on patient connectivity. Meaning, I've been coaching clinicians for 20 years. I've watched clinicians in the exam room. I've individually coached 800 clinicians. We introduced the positive bias of a coach being in the exam room, and the things that I see clinicians do, it's pretty extraordinary. And they're not malicious. They're just unaware. They never learned it. And to hold clinicians accountable for things like patient connectivity and the profound impact of patients saying, I will pay more and drive further to stay here, we have to coach and develop those skills. So having a systemic skill building approach that allows that to manifest is proof that we're not just measuring patient satisfaction and doling out dashboards, but we're listening to the voice of our patients, and we're building the skills in a coaching culture, continual mastery. So the basic fundamentals of patient connectivity is manifesting. And again, not to go down the rabbit hole too far, but if you were to talk about a composite of skills like patient participation in treatment decisions, critical to population health, critical to patient participation, critical in patient empowerment and participatory care. Everybody would get that right in a multiple choice test. But the clinician skill of how do you actively do shared decision-making with a patient, and how do you identify what matters to them and cross-reference that to what's actually happening in the exam room? Because we collect historical symptoms with closed-ended questions. We do a physical examination. We create a differential diagnosis. We test against it, and we issue treatment next. So in order for us to manifest this, we have to get this happening across the enterprise. People go, how'd you go from 6th percentile to 93rd percentile? We coached and developed our care teams on how to do it. And what we have also found is that when clinicians are crushing it behind the exam room door, is the greatest source of oxytocin and dopamine that clinicians can have. And we actually have a study that's now published that we did with Northwell, that when clinicians are coached on patient connectivity skills, all domain significant improvement in patient connectivity, even greater Maslow reduction. And you ask clinicians, tell me about the best clinical moment you've ever had, the thing that you cherish about being a clinician, and allow them to think and reflect and tell their story. It's always about relationships and impact. It's never in clinical sequelae. It's, I made a difference in the lives of patients. And often it's in the context of clinical failure. It's a patient who died whose memorial service we went to. And allowing those moments to manifest, fueled by the skills that are playing out with patients in an organization that not just doesn't say patients come first here. Shut up, everybody says that. We're building the skills and certifying our clinicians in connectivity and telling stories and harvesting the amazing moments that occur that represents the very best of medicine and are incredibly restorative when at a time when clinicians are just getting pummeled. You go home after a really busy day and patients hug you at the end of a clinical encounter and say, you are the best, you have no idea the difference that you made. That is what we mean by patient-centered. That we have a patient advisory board, that the voice of patients guides the decisions we make. And they're highly visible in providing us feedback. And we're recognizing, and we kick off every single meeting with an impact story. And we take great pride in becoming kind and compassionate for every patient every time. That's just who we are. And to be able to say that beyond the depth of patients come first here, but let me show you what I mean by that. We coach, train, and develop every single one of our clinicians. We certify every clinician in patient connectivity. We incentivize those that complete the coaching and do better in patient interactions. We have a patient advisory board that guides us on what we can do best. We're continuously learning on how we can become better for our patients to allow you to be the clinician that you hope to be and to recreate the moments that represent the best of medicine. That's a differentiator, and it's proof that it's authentic and legitimate. All right. Item 2. What am I doing on time? Okay. Item 2 is team collaboration. And we had done some research on this as well. And the collaborative spirit of I have friends at work is immensely important to the vibrancy of your teams. And it's immensely important as a non-tangible, communicated, real property that we can convey of this is what our organizational signature is. And you can see the data. I mean, it's overwhelming. And if you look at the data on loneliness, it's terrifying. I had done a video podcast with Dr. Julianne Holt-Lunstead, who's from she's a Utah University, and she's a neuroscientist, and she talks about the harm of loneliness. And her big meta-analysis that was published in the lay literature actually shows that loneliness, which is about half of the population, loneliness incurs a health risk equivalent to smoking nearly a pack per day. We are, as people, we are not designed to go it alone. We're not designed to be by ourselves. And building a witnessable, collaborative spirit in your organizational profile built with esprit de corps and there for one another is absolutely vital. Not only in terms of serving the recruitment, which I think is important certainly, but equally and perhaps more important is building a collaborative spirit with the clinicians that are within the organization. So, and there was an interesting study that was done out of the university a number of years ago on these basic fundamental drivers of human contentment that crossed time, cultures, ages, demographics. And what they found was three basic things that I think is very consistent with high performing organizations that can recruit the best of talent, where people will line up to work. Number one, in no particular order, number one was mastery. The process of achieving, accomplishing, continuously improving, and constantly developing on things that really matter to us. And I think conveying and signaling that, whether you're building patient connectivity skills or team collaboration skills or leadership skills or wellness skills, these are all endeavors that represent a set of skills that create a set of behaviors that can drive measurable qualitative and quantitative outcomes. And so the mastery journey is an important feature. And great organizations will develop it, will invest in their people. And Gallup came out with this very interesting engagement study out of healthcare, but they found that the one organizational property that was most correlated with engagement was, my organization helps me to grow and develop. And so building the skills of clinicians to be incredibly successful with patients as a local team leader, as a collaborator, as a colleague, there's good literature that drives contentment. The second thing that they found was authenticity, meaning I am living my life according to my deepest held beliefs, what I believe, and my compass, my do this and don't do this in life, that thing, that code inside of me is, this place allows me to be that. And that confluence between who I aspire to be and who I am is, many believe, the source of happiness. And I don't know any physician who, finished residency 20 years ago and says, hey, 20 years from now, I want to be incredibly cynical, negative, fixed mindset, and exhausted. That's my hope and dream. They don't even like themselves. And so, understanding that building a place that allows clinicians to be who they aspire to be is important in building contentment, but it's an important signature feature of what prompts clinicians to make decisions. And the third, as Kristine had mentioned, was belonging. And the ability to feel a sense of we're together. And it can manifest in all sorts of different ways. Silly things like steps per day competitions at the clinical microsystem level, fantasy football, celebrating each other's birthdays, creating a sense of there for each other. And particularly in times like this, that we text each other, we check in on each other, we lift each other up. We have monthly happy hours, and sometimes it's virtual, to get together and talk about how hard it is to be a clinician right now. They'll do themed forums. How do we manage doctoring and parenting? Bring your favorite bottle of wine, and we'll talk, and we'll share our dark teachers, and we'll talk together. We'll have an opportunity to meet with each other, and in the sense of we are a team. We have developed team collaboration skills, and give you a more concrete example. Being a good colleague to each other. If you're not that in our organization, that'll get you fired. You've got to be a good colleague. And again, part of being a champion and part of being, a part of the Tampa Bay Bucks, or, is different from being a New York Jet. I apologize for if I've been insulting people from New York, but But part of building a champion culture is we have expectations for what it means to be us. And clinicians have no problems with expectations. They just want to be able to have the resources and the leadership responsiveness to capacitate them to be their best. An interesting study was done a number of years ago, looking at predictors of what makes for great clinicians. And they took a cohort of ear, nose, and throat surgeons out of WashU. And they looked at all these different parameters, and these ENT physicians at the end of their chief year, or at the end of their residency, the attendings rated certain ENT surgeons as great surgeons. How they were in the operating room, how they were with patients, how they were with colleagues, how they were with their teams as team leaders in the OR, all these sort of technical and cultural attributes. And then they went back in time to identify what are the things that could have predicted them becoming the great surgeons later on. And they looked at board scores and interview performance and training and background and demographics and age, all these different things, and nothing panned out except for one variable. And that one variable was their participation in competitive team sports. They even looked at individual sports like golfing, and it didn't pan out, or music, it didn't pan out. It was people that are used to working within teams and building a place that is built on team care, that is built on we're in this together, that is built on being a great teammate is just a requirement here. And we coached and trained our clinicians on how to be a good colleague, because you can't leave that to chance. So the 3 coaching tips, if you will, for being a good colleague was, number 1, sending good referrals. So when you send a crappy, dumpy referral to a colleague, it creates division, resentment, and backroom chatter about another department and fractures a culture. So appropriate workups according to care guidelines and position, and not dumping on your colleagues. Number 2, positioning colleagues well. I'm going to have you see Dr. Gillespie for your atrial fibrillation. One of the best cardiologists around. If my family had atrial fibrillation, that's the cardiologist we're seeing. And so we build that as not an as ad hoc event, but that's what it means to be us and to be a good colleague. And 3, we are there for each other. If you're a neurologist and you get a call at 4:30 from a primary care physician saying, I got a patient with a cervical radiculopathy with some C6, C7 weakness that's worse than it was yesterday, and really worried about this guy, can you take a look? The neurologist says, send him on down, I'll take care of it. And to have those things palpable as a collaborative culture that we can signal to recruits, and more importantly, we can actually be that as an organization, because this is perhaps the most protective element to clinician burnout is I'm with a tribe. We care about each other. We look out for each other, and we're going to get through this together. We're going through some shared suffering right now, but I have people that have got my back and I got theirs. We'll get through this. And that is a critical differentiating organizational feature. So collaboration manifested. We have a mentorship program, meaning we built a mentorship program. Every new clinician that joins is mentored by a seasoned clinician that can drop attrition to almost 0. And they're simply there for them on all the different things of, it's 4:30 on a Friday, I need to get a leg ultrasound. What do I do? Where do I go? Oh, I got you. And, I'm in a place that supports me. And these are things that you can signal. We can say, we have a collaborative environment. Yeah, everybody says that. Let me show you what I mean. That's the, wow, you really actually have it. We have a peer support system that allows clinicians to seek help when they struggle, because we know this is going to be a hard time. We sponsor monthly dinners. Mayo Clinic's data that show that clinicians getting together for fellowship on a monthly basis had a radical impact on burnout, because collaboration, esprit de corps, friendships, we want to foster that within the group. We have journal clubs, we have a Peloton group, we have whatever, you make it up. But we have real, tangible, and specific things that allow clinicians to form friendships, to look out for each other. I was just on the phone an hour ago with Mark Hertling, who's a general in the Army. He's done a lot of physician leadership development. He talked about having battle buddies in the Army as part of basic training. We have battle buddies somebody that you always can go to, somebody that will be at your side, that you can go to them. And that's just what we do in our organization. So as you differentiate, we are dedicated to patients. Let me show you what I mean by that. We are collaborative in spirit. Let me show you what I mean by that. And the third is our leadership. And Kristine talked about building these organizational cultures and getting burden out of the way. And Mayo has demonstrated, as others have, and we all intrinsically know, that how the organization is led has profound impact on the culture that we create. And that culture that we create is what we pull from as our recruitment funnel. Because if you just have the recruitment funnel, but all this is fake, then that's not going to work. You're not going to have any verification proof. And they begin to talk with their colleagues, and they have lunch with a colleague inside the organization and on this side, and they go, what? That's not what I heard over here. So we got to have, this has got to be a byproduct of this. And this is principally determined by leadership. It is, leadership has a profound impact on the culture of an organization. And one of the questions I wanted to ask Kristine, and if she's on later, maybe we can banter about, is that there's a rising priority around the well-being of clinicians. Are we sourcing it? Are we investing in it? And I think part of the challenge is that we as clinicians soldier on no matter what. That has enabled the disregarding of the engagement of us. It's allowed us to be subject to burnout conditions because we just keep taking care of patients no matter what, even if it's at our own demise. I had dinner last week with Corey Feist, who some of you may know, is the brother-in-law of Lorna Breen, who's the ER physician with no history of mental health, was dropped into the apocalypse of the initial COVID outbreak and essentially became catatonic, and eventually took her own life. And you know, there was no chance and no opportunity to be able to raise their hand. There was no leadership that advocated for the well-being of clinicians, because she and thousands others like her, we just keep soldiering on. So leadership has to have an authentic, legitimate perspective that the people that work in this organization are the instruments by which all things are done. And if we don't take care of them, nothing will manifest. And again, as I said in the beginning, if I had my druthers, engagement of the team should be the singular CEO accountability, reportable to the board and reportable to CMS and incentive. So we sometimes skip that step. All right. So what do we do? So leadership manifested. So if, you know, we can talk about the leadership behaviors that drive engagement, and that's critical in investing in leadership skills and leadership selection, and leadership accountabilities are paramount. Here are 12 clinician sentiments that if that recruit had lunch with any of your clinicians, this is what they would say. In order for them to say this, leaders have to do certain behaviors. They have to do witnessable words and actions that manifest in the clinician saying, I am valued and appreciated here. I got a call from the CEO. I'm a hospitalist. I got a call from the CEO who was rounding on patients and talking about our multidisciplinary rounding and the profound impact it had on the family, on the patient, on the nurses. And she called me up and thanked me. It was unreal. My voice is heard, meaning we have a seat at the table. There's a spirit of deference to clinicians to harvest from the clinical front line to raise team intelligence. I'm cared about. You know, what are the things that leaders can do? And your leaders can figure that out, but the things that are signals that we care about you. I have a chance to contribute. I learn and grow to be my best. I am in the know. There's robust communication channels regarding what we're doing and why, and the intentions of our decisions and where we are as an organization. With our weekly CEO update, my burden is minimized here. I worked with Centera Medical Group, who had a huge challenge with physician burnout. And they launched what many of you may have heard of called the Home for Dinner campaign, which is getting clinicians out earlier through EHR optimization and coaching, which Kristine had mentioned that as well. And they were able to, in the course of 18 months, improve their patient experience from mid-40s to mid-80s and save $11 million in reducing physician attrition. So we showed in our research, when clinicians feel as though their burden is not being addressed, their administrative burden is not being addressed, their connectivity to patients is reduced 78%. So to go to patient experience without tending to the experience of clinicians is dumb. I don't know how to say it. So anyway, so these are the things. It's okay to not be okay. We have fun together here. We laugh. We bring humor in. I have a Texas Hold'em party at my house. Invite all the staff and all the nurses and all the clinicians on our floor. And we're family. We're family. And to be able to convey those differentiating features, because you're not going to be able to beat Kaiser on the retirement plan, but you can decide who you want to be culturally and leverage that as your signal and messaging, and to say, who are we? And what about us represents what clinicians seek and look for? Ultimately, they want to be in a place that is deeply connected to patients as an authentic, observable, witnessable, legitimate commitment. They want to be in a place that's highly collaborative, where they listen, respond, help, support with a real sense of esprit de corps. And there's witnessable things that verify peer support and mentorship programs and Peloton clubs and fitness clubs and running clubs, or whatever else the creative teams can think about, where there's a real sense of friendship here, and we are good to each other. And we measure, once we define that a collaborative spirit is important, then we not only coach and train the skills of collaborating with a colleague, but we actually measure it. We measure peer review, and we ask colleagues, does this colleague step up when help is needed? Are they helpful to you when you're in a bind? And we use that as the part of the clinician's dashboard. So, so we declare it being a great colleague here. We coach, train, and develop the skills that allow it to manifest, and we measure it to verify it and to track it. So anyway, this gives you a sense of the byproduct of effective leadership and what servant leaders do, and purpose and value-driven leadership does, and what it's like to be able to receive that. So bringing it all home. Recruiting physicians effectively is about being a part of a place that is deeply connected to purpose, highly collaborative with each other, and led by those who see their people as their most important thing. I don't want to be all Pollyanna here. And there are profound challenges in healthcare, but I would contend that our ability to connect with patients and to build organizational commitment and in the exam room resources to allow it to manifest is something that organizations have dominion over. And certainly clinicians can decide who they want to be in that exam. We have the ability and dominion over building a collaborative culture. And we have dominion over what kind of leaders we're going to be and what it means to be a leader here, and how we develop leaders with what we sometimes refer to as the P12, which is the 12 leader behaviors that manifest in high degrees of engagement. And it's all the things that we know to be true: self-awareness, growth mindset, vulnerability, building trust, listening, gratitude, all the things that make for leaders who prompt clinicians to say, I'm going to stay here. I would recommend this place. I'm going to access my discretionary effort. And I kind of look forward to going to work, despite the fact that we're getting pretty beat up right now. It's just, it's an amazing crew, an amazing mission. And I would just stand on the rooftop and say, you got to come here because this place rocks. So those are the untraditional elements of physician recruitment. And so I've finished a little bit early, but would love to strike up a conversation regarding, kind of what you're seeing and the challenges you have, and how we might specify the key differentiators of the power of patient connectivity and purpose, the power of team collaboration, and the power of leadership commitment and observable behaviors, and the verification proof that those things are visible, tangible, and witnessable, and to distill those into a communication to differentiate your organization from others. So with that, Matt, if we have I see some questions coming in, and happy to field some questions if we've got some in the queue.
I'd like to say thank you very much on behalf of the NEJM Career Center team, because that was an awesome presentation, really cool insight to have. As you mentioned at the beginning of this, a lot of the folks on this, on the Zoom chat are familiar with the traditional elements of recruiting, and I think what a lot of us try to do is put ourselves in the shoes or behind the eyes of a physician, but it's really hard to do unless you actually are one and you're experiencing what it's like to go through those particular circumstances. So really cool to be able to have that insight. I want to thank you first to begin there. But yeah, we do have some questions here that I think would be helpful to go through for our audience. Someone that just came through, so I will address that one first. What metrics do you recommend including on, a dashboard for analyzing success?
Yeah, for a clinician or a recruiter?
It's a good question. I would say from a recruiter's perspective, for a recruiter or for an organization, what would you want to have on that dashboard? Because that can then translate to what you can communicate to either your current staff or the physicians that you're recruiting.
Yeah, so I'll try to create some confluence between those. Let me start with the motor end plate of the clinician. So we measure the things that we ascribe to be important. So what it means to be a clinician here, and here can be your organization, is we are deeply connected to patients, right? I mean, that's an important metric. So we measure patient experience. It's important to be really good with your staff, right? Because the interaction between clinician and staff, again, that one gets you fired in our organization. So we measure that. Staff provide feedback in terms of listens, supports, honors, respects, teaches, all the things of what it means to be for our staff members. So we staff review, we do colleague review, as I mentioned. These are simple survey monkey questions that we pulse. And we try to get about a sample size of about 20 per calendar year. But those things, our interaction with colleagues, our interaction with staff, our interaction with patients are important, but so is clinical quality, right? I mean, if you're an amazing communicator and a clinical hack, well, then you're a charlatan, right? I mean, so you gotta measure clinical quality. So everybody's got their composites, HEDIS criteria, whatever, for that. We measure meeting attendance because we think that being a part of a group is that you show up. And so, part of that is meeting attendance, and our responsibility is to make meetings good enough to where people get value out of it. And particularly in San Diego, we're trying to bend the cost curve, and we have a capitated revenue stream principally. We will measure cost per episode of care, and we will collect data on complex imaging utilization, laboratory per member per month costs, pharmacy costs. We're very data-rich environment, and so those are some of the things that we have in the dashboard. We also have two other things that are important to know. You're not allowed to measure anything without giving resources to improve it, because you can't hold clinicians accountable for being a great local team leader without coaching, training, and developing them to be a local great team leader, because I sure as heck can guarantee you the variance around that is all over the place, right? So, you know, as we develop data gathering, we have to have data response. So, so we do, you know, colleague review. We don't just ask people, we say, this is what it means to be us, based upon a collaborative effort with all the colleagues of, these are the 3 bullet points of what it means to be a colleague here. We'll coach, train, and develop it. Now we're going to measure it. So then there's the full data collection, data response arc. You know, there's clinical pathways for complex imaging utilization. If you're 2x more complex imaging than anybody else in the family medicine department, well, then there are clinical guidelines, you know, that we embed as part of decision support to help clinicians respond to that data adaptively. So those are data points, and you know, and Kristine had mentioned this as well. The idea of co-design. Clinicians, we shouldn't top down a dashboard. Clinicians should be designing the dashboard, and the dashboard metrics are, how do we quantify and verify what it means to be us? And if it's not important, then don't measure it. And we don't measure it simply to map to regulatory environment, because we try to get as much overlay as we can, and most payers are reasonable in regards to things that they're trying to measure. But we try it to be a quantitative reflection of, we want clinicians that are amazing with patients, amazing colleagues, amazing with their staff, stewardship mindset, clinically efficient, and clinically strong. Would we agree that those are the clinicians we want? Great. What do we measure to verify those things? That's our dashboard. And the last point I would use would be to be sure that your measures never trump your mission. It's a process called surrogation, and you allow the metric to somehow become the mission. And the metric is subservient and a child of the mission. Our mission is compassion, kindness, listening, every patient, every time. The child of that is, are we doing it? We can't let the child rule the house. You must improve your patient satisfaction scores. 50% of clinicians admit to doing medically inappropriate care out of fear the patient's going to be given a patient satisfaction survey. That is pathognomonic for surrogation. And you can ask Wells Fargo how that works out. They allowed numbers of accounts per account manager to dictate what their mission was. It wasn't, how do we best serve the financial needs? It was, they inverted it, and they got all sorts of illegal, nefarious behavior that almost took down, you know, a massive financial institution. So the process of surrogation, you can't let your data do that.
Right, rule the mission. Yeah. What I'm hearing from key themes is obviously defining what your KPIs are on that dashboard, right? And that it's collaborative, right? So it's not a one-way communication of what these KPIs are. Those, you know, and then one of the ones what I really liked about what you said was, we're not measuring it if we don't think we have a solution for it. Right? Because that can really complicate things. I love to analyze data, but to your point, if there's no solution for it, why are we looking at it?
Right.
I love that.
It's unfair. I mean, I've literally had physicians in tears while being coached, because they don't know why patients say what they say about it. They didn't show up saying, I'm going to make sure that I confuse this patient and make sure they go home and say, I had a horrible physician experience. They don't know. They're trying super hard. And nobody ever mentored, nobody ever showed them how, and they're amazing students. And so it's really important. Just one final point on the surrogation issue: as we build dashboards, it's defining collaboratively with everybody at not everybody, but physician leadership representation at the table, first defining what it means to be us, and cultivating a sense of shared purpose. Data only, the lever arm of data, meaning lever arm, if you remember physics, lever arm is the torque that you can create by the longer lever arm, more power, comes from shared purpose. If we say being a collaborative colleague is keeping patients alive and the most important cultural feature of our organization, do we agree that being a great colleague is a requirement here? Well, oh yeah, we're all in agreement. It's critical. I'm doing it. We just expect it, right? We have our shared purpose, and data outside of shared purpose just gets annihilated. And so you have to, when we use data, it's powerful, but it only gets traction when it's a quantitative manifestation where everybody has a voice, and that's what we want to be for our teams, for our colleagues, for our patients. So,
yeah, I think that makes a lot of sense. I have a question here about RVUs, and the question is, how do you get around the RVU portion of the model that may not be met by a physician, and how does the organization support that physician? And I can read that again if you need me to.
Yeah, no, I got it.
Okay.
It's an interesting question, and if you look at the most powerful behavioral influencers to prompt clinicians to change their behavior, it is, and I'll cite a study, and then we'll draw it over to the RVU issue, because I think it's a broader issue of how do we change clinician effort, right? And so there's a study in the ED looking at physician inappropriate use of antibiotics for bronchitis, which is almost always viral. And if you code for bronchitis and give antibiotics, that's like a ding, right? So they tried multiple different interventions, decision support in the EHR, red book recommendations on appropriate use of antibiotics, even private data of what they're doing on a per case basis. The only thing that actually impacted their effort and their attention is, how do I stack up compared to others? So when they see their name and they see where they are, and we're entirely transparent in regards to what everybody's doing for RVUs, it strikes up a conversation. And we have to set the context as leadership teams of, this is what the RVU threshold is, and this what's on the line for this. And then it's making sure that they have adequate response on throughput to be able to optimize productivity. And we may even send a coach. I coached a clinician not long ago who literally could never get out of an exam room. She was seeing like 7 patients per half day. And I watched her, and it was down every single rabbit hole. And I go, we're going to change how you do things here. So there's some diagnostics that need to occur as to why that might be happening. It's the provision of transparent data and where they are relative to others. I can tell you that our data in terms of patient experience, cost of care, and even what we call RAF scores, if you're familiar with that, and HCC Medicare Advantage coding of complexity of care and how complex the diagnosis is totally transparent. So I see how I stack up compared to everybody else, which no clinician wants to be at the bottom of any database. So they go, oh, and then it just opens up the conversation for, hey, we'd love to help. We've got specialists that help with throughput and efficiency. And let's talk a little bit about how we might be able to help, given that you're below. So those are a couple of the levers when people are below the RVU threshold. But it's also, we talk about discretionary effort. When clinicians feel unheard, uncared about, unlistened to, and blown off, and they feel like an RVU center, they're like, I'm going to do the minimum and get out of here as soon as I can. I mean, clinicians always take care of patients, but the discretionary effort to go and dig deeper sometimes is off a bit.
So it's sort of twofold. It's definitely a conversation from what I'm hearing, and it's sort of understanding, is this a coaching circumstance, or is this a physician who may not be happy with their current situation, and that needs to be addressed and discover, sort of pulling back the rocks as to why they're actually unsatisfied, right, and acting like that.
Yeah, I always assume good intent, just worldview. Life is easier that way, and that we've got to do some root cause analysis and as to why that may be. But I think transparent data is an entryway to the conversation.
Mm-hmm. Yeah. So, Dr. Beeson, I know you had some conversation, some question you wanted to have with Dr. Olson. I have one more question that came in from our audience that I'd like to run by you. And, if there was something that, I think you and Dr. Olson could probably talk for another hour based on the knowledge base you have. But I do think there was something that you had to share with her for her input as well. So I'll try to make this quick. The question I got from the crowd here is RE collaboration and getting your teams together. With more care delivery organizations no longer being geographically local or operating more in the virtual space, what are your thoughts on ways to demonstrate or actually practice authentic collaboration? When getting together for meals or celebrations, social groups, you can't do some of those things when you're widely dispersed. Any thoughts on how to achieve that, or examples that you might be able to speak to?
Yeah, I would love to hear Kristine's counter on this one, but I can tell you from personal experience and dealing and managing health systems that are all trying to crack that nut, it's really, really hard. Tomorrow I'm leaving for Banner Health and doing an on-site, but I'm actually going to be doing it virtually with clinicians in a different room. It's bizarre. So anyway,
that's a new one.
I don't know why I'm flying out there, but anyway, so I believe that we can have the spirit of collaboration virtually, even though we know that it's not the same. The company that I run, which is Practicing Excellence, we get together every other Thursday for our happy hour, and we used to be in the same building together, and we're now 100% virtual. So, and it is my family. That's not my family. That's, I care deeply about each and every one of them. So we get together for a happy hour sort of activity that we're able to talk about things that are not work, and it's really fun. And it's not the same, but we have to adapt to circumstances around us and do the very, very best we can. We have made efforts to get smaller groups together to be able to spend some time together. So it's just a admittedly very, very difficult set of circumstances. But I think that there's some great icebreaker activities that allow people to let down their guard, be vulnerable, and to share what they're going through in a well-facilitated session. So I don't know, Kristine, what you guys are doing and what you're trying.
Yeah, I do think that commensality groups, you mentioned the Mayo Compass groups, the commensality groups that they have with the time to decompress, share the experience of work, and share a meal. We would have liked to have done that, but we weren't able to. So what we did was adapted to Zoom format, and we did True North groups. Bill George has a True North group facilitation guide on learning your authentic leadership and using a resiliency-based framework. And so it's a chance for these small groups to still get together by Zoom and to re-engage in your mission, your meaning, what brought you to medicine, share that with others, hear from others, be inspired by others, be vulnerable, be supported, and to just reconnect with what it's all about. What's your why? And how do you get there? And what do you need to do to support that why?
Mhm.
At this point with what you're dealing with, the pandemic or with burnout. So that has been a great series, very highly regarded, popular series. So
Mhm.
in a way of engaging leadership, I think is to have a very discrete program you'd like to do. We did a pilot, we got some good results back from it. So we now have that to show. And it really brought people together, made people feel connected and supported. So now each of those people can become facilitators. It's peer
Right.
peer
Right,
support.
and they start to tell the story as advocates for the power of that camaraderie. Those are great. Those are great guiding tips. So, go ahead, Matthew.
Oh, man, I was just going to say, it almost sounds like it's less about the what and it's more about the why, right? Is just find a way to get people together and get them to be engaged and have a meaning behind why you're getting together. And you will be successful. And I like the concept you bring up about creating advocates. And sort of continuing to spread that theme throughout the organization, because in terms of having an identity, that's how you create an identity. You can think about your DNA as X, but if there aren't others that believe it and share it, you're not going to be able to actually cement that as the foundation of who you are.
We did one thing that didn't have necessarily meaning, but really brought people together. And we had a colleague who did some laugh work with us. It's something that he'd learned from his physician father, and he taught us as physicians, and just got together to laugh. And it was silly, and you had to be a little vulnerable, but it made you feel closer to your colleagues in the end that you did that. That you kind of exposed yourself that way, and people felt closer. And then they made a little joke to one another if they give a Santa laugh or this kind of laugh to one another. It's an inside joke. Very contagious.
Yeah, I can tell you about one of the happy hour themes that we had done. It was a total bomb, but I thought it was a good idea. But it's along the lines, but not as clever. And Joey's on the phone, and she can attest to what a bomb this was. But it was giving everybody a line, like in a script, and they have to act it out. And it was.
Oh, I love it. I love it.
It's
improv, right?
I think that that's got to be a happy hour, if you know what I mean.
Yeah.
So a little disinhibition, but
what is it? A comedy club, 2-drink minimum.
Right, exactly. So, but I think just getting together, and there's another one that I participated in that was themed around my darkest teacher, and it was, what's the hardest thing you've ever been through, and how has it made it you who you are today? Mm-hmm. And oh God, talking about raw. I mean, just unbelievable stuff. There's crying and just, and to realize that human struggle is part of the human experience, and our most difficult times make us who we are, and, we had a physician who shared a story about when she was first in clinical practice. She had a patient come in that was tangential and disorganized, poor historian, and she was sort of irritated, blew him off, and said, come back in a few weeks for your physical and get your labs done before, and just was in a hurry. And anyway, the patient left, didn't think about anything about it. The next day, the patient comes in, or the detectives come in, and come to find out that the patient had left that clinical visit and drove to a mountaintop and put a bullet in his head. And, she shared in tears, and everybody else was crying, about how that has made her who she is today. And a great sense of understanding and empathy and struggle and curiosity. She goes, that has made me like totally different physician. And those tragedies are never blessings, but that kind of themed thing, I think, can break through some of the virtual barriers that people see, and it just creates that sense of belonging. And the weird talk track that I have in my head that says the world is over as we know it, oh, you too.
Yeah.
So and normalizing some of the struggle a little bit, I think is an important belonging activity that we can overcome sometimes virtually, partially.
Absolutely. We've been doing some post-traumatic growth sessions because the pandemic, we couldn't go over it, couldn't go around it, couldn't go under it. We all went through it.
Yep.
And as we have gotten together to share how that's been kind of a crucible moment, how that has shaped us, formed us, how we found out who showed up for us, which colleagues were there for us, how we felt closer to one another, from those who helped us through it. The various types of sharing and the vulnerability that people shared also of how they felt, how it was difficult, their losses and things, is that we came together as a community and we saw how much that we share in common, and that what we're experiencing and feeling is not just ours alone. And that is really helps to build and bring us together as a community. It's powerful to share those stories in a trusted space.
All right, Matt, as conductor of the orchestra, are we reaching the finale?
We are pretty much at the end of our train ride here. I have to say, I think we would all love to be able to continue this conversation longer, but I guess we have actual jobs to do and that kind of thing. So listen, on behalf of NEJM Career Center, on behalf of all the attendees who joined us, I sincerely thank you both. It was a really, really interesting afternoon, or I guess morning for you, Dr. Beeson, and something that I think we'll have some really great takeaways from.